Hello, everyone. I'm Brandon Hawker with the Open Minds Market Intelligence team, and I'd like to welcome all of you to today's Circle Elite Executive Roundtable, the new role for primary care under CalAIM. Today's roundtable, sponsored by Qualifax, features Dr. Sorg, Director of Care Integration and Information Technology, Tarzana Treatment Centers Incorporated, and Mary T. Parra, Practice Manager of Internal Medicine, UC San Diego Health. Jim Sorg, PhD, is the Director of Care Integration and Information Technology at Tarzana Treatment Centers Incorporated. Here, he serves several areas of focus, including access to care, CalAIM Enhanced Care Management and Community Supports, information management, quality assurance, and efforts to further integrate medical and behavioral health care. Dr. Sorg worked as a consultant to behavioral health care organizations for many years prior to his work at Tarzana Treatment Centers, and he received his PhD from Ohio State University's School of Public Policy and Management. Mary Parra is Practice Manager of Internal Medicine at UC San Diego Health and has over 20 years of experience in the health and human services field with expertise in value-based reimbursement strategies, clinical care redesign, marketing and communication, board-level strategic planning, clinical service line business development, hospital performance improvement, managed care contracting operations, community health center operations, and clinical and administrative staff supervision. Ms. Parra serves as Director of Operations with Neighborhood Healthcare in San Diego. In this role, she led day-to-day regional operations for medical and dental health centers in San Diego and Riverside counties. As a member of the organization's leadership and operations senior management teams, Ms. Parra is responsible for quality and operational metrics and has directed over 150 employees and managed $21.5 million in annual budgets. Ms. Parra earned her Master's of Public Health Services Administration from San Diego State University, Bachelor's degree in Biological Services from University of California at Irvine, and is a Fellow at the American College of Healthcare Executives. Moderating today's roundtable will be Richard Lewis III, Vice President of Open Minds. As Open Minds Vice President of the Western Region, Richard Lewis brings extensive experience as a behavioral healthcare administrator, business development specialist, and innovator of new service lines for behavioral healthcare organizations. His expertise in population health management, program development, strategic planning, and payer mix diversification help create programs that target high cost and complex behavioral health populations. Before we get started, a few housekeeping reminders. As always, your audio will be muted during today's briefing. However, we encourage you to submit any and all questions you may have using the question box on the right side of your screen. We will present audience questions at the end. Finally, the slides and recording from today's briefing will be available on the Open Minds website by tomorrow. Richard, I'll turn it over to you.
Thank you, Brandon. And good morning, and thank you, Dr. Sorg and Mary, for joining us today. Brandon mentioned that this is part of our Elite Circle member executive roundtable series that we do. I think it's once a week for members. And today is actually our fourth quarterly California-focused webinar, kind of featuring payers, providers that are innovating the new CalAIM landscape here in California, which we're going to talk a little bit about today. Like many states that have gone before us, California is one of the last county mental health system driven Medicaid system left, and here in California, Medicaid we call Medi-Cal. Under the 11515 waiver, we finally have a mandate to move our Medicaid system or Medi-Cal more from a fee-for-service cost-based reimbursement model to more of a value-based and whole person care model for the delivery of services for complex folks. Some of the key reforms are the introduction of population health management type tools and services to serve the Medi-Cal population here in California, our movement towards value and performance-based care for Medi-Cal populations, the introduction of in lieu of services, or our ability to address social determinants of health for folks, especially those that are high risk for hospitalization and incarceration and those types of things, and from the lessons learned from our county whole person care pilots and the health homes programs that our managed care plans had conducted over the past few years, the introduction this year of enhanced care management. Yeah, this is our first year in CalAIM, so at the tail end of that. And some of the things that we've seen is the beginning of being able to move the needle a bit from fee-for-service to value-based reimbursement approaches. Our managed care plan contracts this year for in lieu of services and in the enhanced case managers are, largely case rates and bundle rates and those types of things. The all part of the population health strategies that the managed care plans are implementing here, again, targeting our more complex populations. We talked a little bit a minute ago about the enhanced care management or addressing social determinants under the 14 in lieu of services. These are just the first glimpses of what CalAIM transformation will look like here in California. We're seeing the managed care plans for the first time having a more expanded role and expanded benefits for adults with severe mental illness, and starting next year, kids with social emotional disorders. We're seeing a lot more partnership and communication between our provider networks, our providers here in California, and the health plans to develop these new core services to align reimbursement models with service delivery to meet established outcomes. And I think the other thing we're seeing in this first year is kind of a new landscape for competition for our specialty providers here in California, as we've seen in other states that have moved already into managed care and value-based models of care. And that is more competition from our county mental health departments and federally qualified health centers that are playing more of a role in service delivery of health plan members. Before we introduce our first presenter, which would be Dr. Sorg, kind of a glimpse of how we view that for provider organizations, the need to have some type of a sustainability strategy to remain competitive in this new CalAIM environment here. It's a heavy lift moving for our providers here in California from cost-based fee-for-service contracts, under our behavioral health systems to a more fee-for-service and ultimately value-based reimbursement type of model of care. To do that, we're seeing a lot of innovation in terms of how we build these new provider service delivery mousetraps in conjunction with the health plans and county mental health systems. Our ability to develop new services is part of the transformation to CalAIM. The implementation of new technology for addressing issues related to health plan goals like timely access to care, population health management, those types of things. Our flexibility as providers in a whole person care and in a person-centered care, models, starting to look at being able to wrap our hands around new treatment populations. And today we're going to talk about, addressing the primary care needs of our behavioral health populations if we're as behavioral health care providers under these new models. And certainly the new partnerships that'll be required for providers to position in the market to be able to deliver those whole person services, whether that be through a strategic alliance, whether the providers, primary care providers, or merger acquisition type activities. All of these are the things that we're seeing as the sustainability planning for our providers here in California and of course nationally, all to bring improved performance, reduce cost, and be able to demonstrate value in the services that we're providing, and carve out a competitive advantage in the markets that we serve. With that, I'd like to introduce Dr. Sorg, who's going to talk with us a little bit about the Tarzana Treatment Center model. When we talk about integrated care, integrated care means a lot of things. And for today's conversation, it's really talking about how do we integrate, primary care and behavioral health care together to kind of meet those whole person care requirements for addressing all the needs of clients in our Medicaid system. With that, I'll introduce Dr. Sorg.
Good morning. Thank you, Richard. So next slide, please. There we go. So my plan for I've got 20 minutes. I hope I can contain my comments in 20 minutes. I'm going to define CalAIM in a little different way than Richard did. I'm going to talk about aspects of a new role for primary care under CalAIM. I'm going to cite a framework for care integration, which is the role for primary care under CalAIM that I want to focus on today. I'm going to talk about Tarzana Treatment Center's model of integrated care, and then talk about some of the nuts and bolts of implementing integrated care. I see I have a typo in my slides. Integrated care in the context of CalAIM. Next slide, please. So the goals of CalAIM, as Richard said, I'll go through these quickly, are to identify comprehensive needs through whole person care approaches and social driver of health, improve quality outcomes, reduce health disparities, transform delivery system, end up with payment reform, make Medi-Cal a more consistent and seamless system for enrollees to navigate by reducing complexity and increasing flexibility. That's going to be challenging. And the new roles for envisioned for primary care under CalAIM include enhanced care management and community supports that we've mentioned. And I'm not going to dwell on those. Tarzana is a provider of enhanced care management and community supports, and hopes to expand into many of the 14. And I'm going to spend most of my time talking about how Tarzana contributes to whole person care via care integration. So next slide, thank you. So earlier this year, there was a publication by Logan Kelly, Center for Healthcare Strategies, that called How California Can Build on CalAIM to Better Integrate Physical and Behavioral Health Care. And he mentions three aspects of care integration: financial integration in initiatives, administrative integration initiatives, and clinical integration. I'm going to focus today on clinical integration. The financial and administrative integration are not under my purview, right? They're state and county health plan activities, not anything I can do anything about. I have to live within that framework, those elements of the framework that they create, and manage to produce clinical integration, sometimes in spite of what they've done or not done yet. So next slide, please. Logan Kelly says that about clinical integration, initiatives to achieve clinical integration often encounter barriers related to financial and administrative fragmentation, such as misalignments in funding and data reporting requirements. So Tarzana has managed to produce clinical integration without the support of administrative and clinical facilitators, in spite of those. And I'm going to talk next about Tarzana Treatment Center's model, which goes back decades, and then come to those mechanisms that I mentioned. So next slide, please. So Tarzana was founded in 1972, and we're located in LA County. We deliver services to other counties throughout the state of California, but all of our facilities are located within LA County. And we're a provider of integrated behavioral health care and primary care. We have a hospital, residential alcohol and drug beds, outpatient SUD services, mental health services. This says health home services and home health services. Where these health home services are now enhanced care management services. We have 6 FQHC lookalike clinics. We do housing and peer support services, and we just started this past year, year and a half ago, TTC College, where we're training counselors and other disciplines. We're accredited by the Joint Commission and licensed by California and counties. Next slide. So we serve about 19 to 20,000 a year. I'm not going to go through all of this. Please, next slide. You can look at these later. This is a map of LA County and the location of our services. There's 60 miles between Lancaster and Long Beach. So it's quite a big county. And this is actually out of date. We have more facilities than this by now. Next slide. So our comprehensive system of care is tied together by care integration. This is what I'm going to be talking about today. So we have access to care services. We're 24/7 access to care. You can call us up. You can walk in to some of our facilities, not all of our facilities. Our hospital is open 24/7. We have phone service, call centers operating 24/7. We have a team of people who do. We have a call center, but we also have a team of navigators that I supervise who facilitate access to care. So it's the aim of what we're trying to do is make it easy to access our care. You don't have to know who to call. You know, we'll assess you and place you and connect you to the services. We have a 60-bed acute psych hospital that does SUD withdrawal management and psychiatric care. 400 plus residential SUD beds. And as I said, outpatient SUD and mental health services, housing, and the clinics, all tied together by care integration. Next slide. Another view of those services, and I'm going to be talking about our care coordination. So next slide. A model of our whole person care approach. Next slide. Here's our mission, and at the top, and a model of our mission on the bottom. So this follows the triple aim, if anybody cites that anymore these days. We want to improve access to care, improve the quality of care, improve our business operations, and with the outcomes of improved patient health, reducing the total cost of care, and improving patient experience. That's our mission. And we keep adding services. We're kind of opportunistic, but we have a strategic plan, but every opportunity that comes along, we're likely that will enhance our mission, enable us to serve more people or serve more of the needs of our existing patients. We're likely to go after it. We have a very active grant program development department, and we've got a lot of SAMHSA grants at the moment. So this slide's about our data-driven approach. We not only deliver all these things, we measure them. So our access to care, for example, we measure our same day, next day admission policy? Do we actually deliver on that? It's extremely difficult to do that in some levels of care, given the mismatch between the great demand for SUD services, especially, and the supply. Just not enough inpatient beds, residential beds, housing for SUD patients in recovery, and so on. So that, and then we measure these other items as well. Next slide. More about our data-driven approach. We have, in primary care, we measure a lot that we're required to report to health plans. They report up to the state, and we report to HRSA. We collect a lot of data about patient preventive care, and we work every day to improve our scores on those measures. And as a behavioral health provider, Joint Commission certified, we've got to have outcome measures. We have a lot more outcome measures that we track beyond what what Joint Commission would require. And those, it's more challenging on the behavioral health side, because there's when primary care, we've got a whole infrastructure and years of experience in measuring, and federal and national standards for primary care measures for behavioral health. We're creating these on our own with no infrastructure and little guidance. Next slide. So finally, back to clinical integration and what I said before about the barriers. So how does Tarzana overcome those barriers? How do we manage to produce clinical integration in spite of the barriers? And how has my boss, the CEO of Tarzana, and one of the founders of Tarzana back in 1972, how has he managed to produce an integrated care organization in spite of these barriers? Next slide. So I'm going to talk about what I'm calling mechanisms of care integration. Those are the focus of leadership. Leadership is always mentioned in this context, but I want to talk about particular foci of leadership. How we've used our organizational structure to support care integration. Funding we've used for care integration. I'm going to talk about a couple integration methodologies, and then software applications and data. And I'm going to take these out of this order. This is the, so kind of the logical order. If you're going to talk about what you're doing, you start with leadership, right? That drives it, and you structure an organization, and then you produce processes to implement. But it'll be easier to understand what I'm talking about if I start with the integration methodology. So the next slide is about that. So I'm going to start with the integration methodologies, and there are two of them. One is care coordination. That's what this slide is about. And then there'll be another slide about care cascades. And I'll talk about each of those. So in an organization like Tarzana's, which has hospitals, residential units, outpatient services, and because of the siloed funding for all of these things, and for primary care, these all have directors in charge of them in their own budgets and their own. We have mental health department that we work with for mental health, and a public health and a substance use program department that we work with for substance use disorder, and then we have primary care and the health plans and all of that, all of it. Because of those funding and administrative structures, we end up with silos of SUD, mental health, and primary care. So how do you manage to make how do you manage to provide integrated care in that context? And I'm saying one of the ways we've done it is by using care coordination as a way to bridge between the silos and to get patients referred from one department to another so that they can get, if they're SUD patients, they can get primary care services. Their behavioral health patients, they can, or if they're primary care patients, they can get behavioral health. And one of the ways that we've done that is to have dedicated care coordinators, people whose job it is to provide care coordination, and they're not embedded in those silos. They're independent of those silos. Yes, we have people who provide care coordination within those siloed departments, but in addition to that, we have teams of care coordinators, case managers, navigators, community health workers, whatever you want to call them. We have departments that provide that care coordination. And those care coordinators report to managers external to the silos. They eventually report to me, and because it's my job to be integrating care, linking these departments together. So next slide, please. One of the another tool, another integration methodology that we use is care cascade. This concept, as far as I know, started with HIV/AIDS in the 2000s, and I've adopted it, and we use this concept beyond HIV/AIDS. We use it for HIV/AIDS, but we use it with other chronic conditions as well. So a care cascade is a series of steps that end up getting care to people who need it. And with respect to diabetes, where we screen in behavioral health in our inpatient unit, our residential units, our outpatient programs, we screen for diabetes. This, I'm showing you data from a particular project, a grant-funded state DHCS-funded grant that we got that's running out at the end of this year. That was for people with serious mental illness and diabetes. And we screen them in behavioral health. We identify if they're at risk. We refer them to other services at Tarzana. They run through the care coordination team that I've referred to, who manages this care cascade and makes sure that people move through each of these steps. So they get referred to primary care, they get a blood test, verify their diagnosis, and then these case managers who are dedicated to working with diabetics who have behavioral health issues, that's their job. They make sure they get an appointment with primary care. They get their blood glucose testing. They get, if they're diabetic, they get the preventive care that diabetics need. The ongoing monitoring of their blood glucose, the retinal eye exam, and other steps that they need to take on a regular basis. Some of just interesting, some of these numbers look low it's because we had to go out and get funding to buy retinal cameras and to link those to our primary care EHR. So those numbers are going up at present. And once this grant funding runs out, this team will still be there because we will use drug Medi-Cal ODS case management benefit to work with SUD patients who have diabetes and get them the care they need. And they will serve their other case management needs in a dedicated way. Same with mental health. Next slide. So to do the things that I just mentioned, to have care coordination and to have the energy and focus and resources to do care cascades, we've had to pull funds together from different sources. So starting these are somewhat in chronological order. So the CEO, Albert Sinella, started in the 1980s with HIV/AIDS and resources for that purpose. In the 1990s, he got us involved in primary care. There was a little bit of money available from the County of Los Angeles at that time for primary care. So we've always subsidized primary care. And we used private insurance, private pay, behavioral health contracts and funding. The surplus that generated, we applied to the deficit created by because we were providing primary care. So non-restricted funding streams were used to subsidize the money losing primary care efforts. We're now an FQHC lookalike in the last year or so, and perhaps we'll break even on primary care. We got SAMHSA-funded primary and behavioral health grants in the 2000s, 2009 to 2015. We got 4 of those that helped us integrate primary care with behavioral health, gave us the resource we needed there. We're now using DMC ODS reimbursement for case management to provide care integration. LA County Department of Mental Health, the resources are more slim there. We use those funds. Starting in 2020, CalAIM enhanced care management contracts, and I mentioned a grant that we got from DHCS for SMI and diabetes care. Next slide. So to make this happen, the leadership has been important, and a particular kind of leadership that I'll talk about now. Albert Sinella has wanted from the 80s, that time frame, to provide whole person care, and he's still working on it today. We want to provide every service that patients need in one place. So our facilities provide integrated care. If you go to many of our sites have primary care, SUD treatment, and mental health treatment, and care coordination in those sites. We've worked to implement no wrong door I mentioned the navigation team that we have, and we do a lot of work to assure that people can get from one type of care to another. I'll talk about some of that in a moment. Some of the tools we use for that, and we think of this, we're cross-selling. We want to help. We want to provide this care to the patient, but we're also selling another service. So you're a primary care patient, and we've assessed you as we've done the adverse childhood event screening on you, and we recognize you need behavioral health, and we're going to provide that at Tarzana if it's appropriate for you. So that's those are aspects of leadership that we use. And next slide. Organizational structure. So we have actually 2 points of responsibility. The CEO, who initiated all of this, and but it's my job. I'm the single point of responsibility for promotion of care integration, that's actually my title. That's what I spend most of my time doing, is making sure that we are linking patients from one kind of care to another. And we've got departments, as I mentioned, that are independent of these silos that implement care integration. Substance use, mental health, enhanced care management. We just got a certified community behavioral health clinic grant. And the care coordination for that's going to be external to any of these siloed departments. Medicare chronic care management is another service that we're doing from the outside. We're making sure it happens. It'll be delivered by primary care, but the drivers of that, the staff who drive that, are external to the silos. Next slide. Last slide. Software applications and data mechanisms of integration. We built software ourselves, so we have the things I mentioned. Our access to care effort. We have an access log that we use to track. If you call us, you're going to end up in our access log, so that we don't lose track of you, and that we assess you a little bit on that first contact, and we know from that assessment which of our services you need, so that we can connect you to all of those services. You're going to probably go to that, a single service, but we have a picture of you at that, based on that initial contact that we capture in our access log, that shows what services you will need. Then we have a referral log that we use to refer from primary care to behavioral health, and in the other direction. And finally, we have a data warehouse. We use Avatar, NetSmart's Avatar for behavioral health. We use Epic for primary care. They don't speak to each other, so we've had to build a data warehouse. We pull data out of each system, and if I need a list of patients with diabetes on the behavioral health side, so I can track them and promote their involvement in primary care, I can get it out of the data warehouse, and I can get the same if adverse childhood event screening happens in primary care. They need behavioral health services to treat their trauma. I can refer them in the other direction back to behavioral health, and we use a data warehouse for that purpose. That's the end of my presentation. I hope I did it in 20 minutes. Probably not.
We're doing okay. But thank you, Dr. Sargent. I think for our audience, I think Tarzana Treatment Centers is a good example of a behaviorally health led, integrated primary care model, and really one of the early pioneers here in California and here in Los Angeles County of integrated care. Interesting to see the bundling of, they had to bundle all kinds of different funding sources to make this work to get to where you're at today. And really a really effective model. And with that, we'll move into Mary Parra, who will talk to us about the program and the model that she operates at UC San Diego Health down in Southern California.
Thank you, Richard. Thank you for this opportunity. Why don't we go to the next slide, talk a little bit about UC San Diego Health. Before I dive quickly into our behavioral health care model, just want to say a little bit about UC San Diego. Our mission is to deliver outstanding patient care through commitment to the community, groundbreaking research, and inspired teaching. Our vision is to create a healthier world, one life at a time, through new science, new medicine, and new cures. And we repeatedly, by U.S. World and News Report, are ranked #1 health system in San Diego and #5 in the state of California. So a very proud staff member of UC San Diego Health. So now I'll just dive in quickly to what does integrated behavioral health look like at UC San Diego. Primary care, similar to what Jim was saying, we're looking to treat our patients beyond the physical well-being. And as a result, we are committed, our physicians, our staff, our behavioral health providers, to integrating our primary care for a whole person care approach. And at the core of our IBH, integrated behavioral health, is a whole person care approach that models the primary care providers and the behavioral health providers working together with a goal of enhancing the overall patient's health and well-being. So very similar again to Tarzana. Next slide, Richard. So what does this integrated approach look like at within our primary care locations, which we have typically 2 to 3 BHPs in our clinic working side by side with our primary care health providers. So obviously our goal is that easy access. Jim, reiterated how important access is to the whole person approach. And so we in our clinic provide short-term behavioral health treatment and follow-up. Our behavioral health providers consist of psychologists, marriage and family therapists, clinical social workers, and we offer up to 12 sessions per treatment plan. And our behavioral health providers work very closely with our patients and their PCP to address the patient's combined physical and behavioral health concerns. And I have an example of that a little later in the presentation. And right now we have 10 primary health care locations that have integrated behavioral health within their clinics. So, next slide, Richard. So what are the combined physical and behavioral health concerns that we're addressing in this integrated model? And I have a laundry list here. It's obviously not 100% inclusive, but the main areas of concern and treatment plans are there listed. I'm not going to call them out each. Next slide. So we do use a methodology in our primary care settings that we call T-Care, and it is a critical element of our behavioral health integrated model. And the T-Care is an acronym for Targeted Collaborative Assessment and Response Empowerment. So we're targeted, focusing on the current functioning and identifying goals We're collaborative. Our goal of the encounter is clear and agreed upon between the IBH, PCP, and the patient. The assessment of the behavioral health provider assessing functioning, triaging for referrals. Our response is to fortify the patient's skills and resources for optimal functioning given the circumstances of each individual patient, and we empower. We look to help the patient feel empowered to function well and take an effective action based on the overall collaborative assessment. So next slide. So what is T-Care and what isn't T-Care? T-Care is not administrative health. It's not a one-call psychiatric emergency service, and it's not a check-in service. What it is, again, is a clinical consultation during an in-office or telehealth visit for brief assessment and targeted interventions. It's also assisting physicians and advanced practice providers like nurse practitioners or physician assistants in clinical decision making. And it's an interdisciplinary approach to helping our patients. Next slide. So here's my example. And you can see this is the warm handoff from the PCP to, the patient to the IBH provider. So the physician says to the patient in the exam room, it sounds to me that this chest pain you're experiencing definitely requires a good workup. I want to make sure we cover all the angles. One piece of this may be stress. So while I make sure we check your labs and do an EKG today, I would like you to speak to my colleague, Dr. Sieber, who is our behavioral health provider. He helps me, the physician, make decisions regarding patient's care, your care. So he will talk with me about your conversation with him and what might be some of the ways we can get things moving along in the right direction for you. And then is it okay if I invite him in now for only a 10 minutes while I get some of these other things moving? And then you can see on the right side of the screen, the things that are targeted in this warm handoff are validating the patient's concern and the PCP's intent to fully investigate both the medical and the behavioral, make destigmatizing connections with our psychosocial component of care here, introduce our behavioral health provider by name, much like would be done with a medical assistant or a nurse. And we introduce that consultative role, specifically where the behavioral health provider is going to consult with the PCP after speaking with the patient. And that behavioral health provider is also there to help the patient with any immediate strategies. And we ask permission unapologetically, and we communicate the efficiency of the visit and to allay the patient's concern of timing or whatnot. So that's a nice example that we use. Next slide. So our integrated behavioral health is not psychiatry, although we do have a psychiatrist that is at our clinic routinely seeing patients. We do have options of 3 or less sessions with a psychiatrist to diagnose and or for medication management. And then you can see a grid there below on the slide where it's kind of like we look at the situation with the patient and triage where the patient should be seen in IBH and or psychiatry. Next slide. So again, integrated behavioral health is not just straight psychiatry. It is an approach that includes assessment, triage, time-limited, evidence-based treatment, as well as psychoeducational groups for our patients. Next slide. So recently, and I just want to give a little purview of a case study that we did in our clinic here in La Jolla. We are the largest primary care clinic, actually ambulatory clinic at UCSD Health. So we did a case study with our depression screening, which is one of our key alignment measures that we monitor weekly for the population health of our patients in the communities we serve. So what was happening is that our screening rates were not meeting our goals. And we define a successful screening and follow-up plan to include at least one of the following for our patients: a referral to a practitioner qualified to diagnose and treat for depression, pharmacological interventions, or other interventions to follow up for the diagnosis or treatment of depression. The depression screening is CMS and other health plans covered, and they have incentivized for annual screening for these depression in primary care settings. And this is, to incentivize, to motivate, to ensure accurate diagnosis, effective treatment, and follow-up. And there's also DHS direct payment incentives tied to this screening as well. Next slide. So we had a team for this project. We had our director of faculty primary care. We had our medical director for our internal medicine clinic. We had our practice supervisor, myself, the manager. We had our practice support specialist. We had our lead RN resources, associate clinical professor for psychology, a psychologist, and our UBAR support analyst, which is from our IT team. Next slide. So what we looked at here was that our depression screening rate back about a year ago was only at 69%, and the targeted goal was 78%. And, just to reiterate the importance of this screening, depression is a critical factor which impacts our general medical health. I'm sure many on the line here understand that. And examples of non-treatment of depression can lead to many things, including skipped treatment, non-adherence, increased hospitalization, self-medication through substance abuse, and going to access care in what you would say is the non-appropriate settings, such as the ED, and then also a 50% increased risk of mortality or morbidity. Next slide. So you can see a quick snapshot of what our performance was of our screening rate, and we clearly were not meeting our goal. Next slide. And so we took some actions. We implemented a pilot program that we called a welcome program, implemented it at the beginning of February of this year. We used 12 iPads. We put these in protective cases. I guess we had one break right away, unfortunately. We have serial numbered, and they're pretty much the only thing they can do are screening questionnaires. So reduce that risk of somebody walking out with an iPad. We set in the processes the standard work for our front desk to utilize these welcome iPads and during check-in. And then we also worked with our clinical informatics to measure the usage of this program. Next slide. So here's just an example of our standard work that we put in place for our front desk. Next slide. And again, setting up the welcome tablet with the questionnaires. We use a QR code that the front desk just scans the iPad and gives it to the patient. Next slide. So you can see here when we began this pilot program, our numbers here of our PHQ-2 branching to the PHQ-9 depression questionnaire was only about 113, out of 1,945 of all the questionnaires that we were having patients complete. Next slide. And then by July, after the iPad welcome program was implemented, the PHQ jumped up to be the top questionnaire completed. Prior to implementing this program using iPads, everything was handwritten, paper written, staff would have to manually input the responses, upload the questionnaire into the medical record. It was a very labor-intensive process. Next slide. So if you looked at our questionnaires, you can see the number of questionnaires completed dramatically increased in a few short months. Next slide. And our depression screening rate exceeded our population health target of 78%. I think for this presentation, I pulled it last September, October. But we continue to monitor it. Next slide. We have a morning daily engagement system that we use. This is a huge whiteboard that we track our top 5 alignment measures, and depression is part of the quality measure. And we also use a system called Tableau, a data warehouse, to track our depression screening. And you can see here at the time it would shot up to 82.36, and it continues to increase. I think last week it was above 83%. Next slide. So some lesson learned really quick. Initially we had the timeout for the iPads too soon, and we have quite a bit of elderly patients, so by the time they got to their seat in the lobby and the waiting room and started the questionnaire, the iPad would time out, so we had to extend that. Not all the questionnaires are both in English and Spanish. This was beyond the depression screening. We're using it broader than just depression screening questionnaires. So that was one thing that we implemented. We did have initially one of the iPads crack, so we ordered nice big cases to protect them. And occasionally we'll have our front desk, try and find the iPad, which usually what happens is the patient is not done completing their questionnaire before they get called back. So the nurse will bring it back to the front desk, and we have plenty to use with our patients. Next slide. So we have an Epic, we use Epic, and we have smart sets to help with the depression screening, positive depression screening, and what's next for our providers. Next step, or next slide. And then lastly, this is just kind of a wrap up. We have a mentality of depression as a vital sign in our primary care. We are looking to meet and exceed CMS quality incentive measures, looking at measurements with best practice clinical pathways for our physicians, focusing on improving our access to behavioral health right here in our primary care clinics, and integrating with our psychiatrists as well. And I think that's the end of my presentation. I have like 2 minutes left, Richard.
Good. But Mary, no, thank you. And I think one of the things I like about your presentation is it really does give a good example of the use of technology in with your iPad pilot and the effectiveness of that in doing the initial screenings for depression. So thank you for that. I think we have just a couple minutes for questions or comments. Let me turn it over to Brandon to ask if we have any questions from our audience.
Richard, no audience questions. Is there any points of clarification or more in-depth subjects you'd like to get into yourself?
No, I mean, I think that the Tarzana Treatment Center's example versus the UC San Diego example are just good examples of there is no one cookie cutter approach to solving or building the integrated behavioral health primary care mousetrap. I think we're seeing a lot of different approaches from providers. CCBHCs are a growing model that we're seeing more and more of, and I know Jim talked about them going down that path somewhere down the road. But again, whether it's a primary care setting, integrating behavioral health, or in Tarzana's example, a behavioral health-led, integrated primary care model, they all have different pros and cons. They're all addressing different populations. It's they're all using different approaches, different technologies, different funding. And we're hoping here in California, at least, that that the funding becomes more aligned from the state and through the health plans for us provider organizations to build these models with a little more robust funding than in the Tarzana and Dr. Sarg's example of really just having a piecemeal different types of funding to kind of build what they've got going there. No, I want to thank both of our presenters for giving us a snapshot of both of their models.
We did have one brief question. This is for both of you, just asking, what EHR are you using? And are you happy with it? And does it facilitate integration of care?
We use Epic. We're totally integrated with Epic. And yes, I think we're pretty happy with it. Sometimes the upgrades throw our providers and staff for a loop, but it's always, our teams are always working to make it the most efficient and effective way to treat our patients, as well as to comb the data from it, which goes into our Tableau platform, where that's where, like, myself as a practice manager use Tableau to dashboards galore on almost anything you can imagine to help treat our patients. So it's a nice fit.
Dr. Sword?
We use NetSmart Avatar for behavioral health and Epic for primary care. And I mentioned the data warehouse that we use to integrate the two.
All right, fantastic. Okay, Richard, anything else on your end?
No, just a big thank you to our presenters.
Yeah, thank you again, Ms. Parra and Dr. Sorg. Thank you everyone in the audience for joining us for today's web forum. And a special thank you again to Qualifax for sponsoring today's roundtable. I'd just like to take a minute to remind everyone the slides and recording will be available tomorrow on the Open Minds website. The Full Circle Elite Executive Roundtable series is also available on demand as part of the extensive Open Minds library, and it's also available from the Open Minds YouTube channel as well. Please join us next week for our next roundtable. Sorry, not next week. It's an executive seminar on Thursday, December 1st at 1 p.m. Eastern Time. And the topic will be how to develop a strategic plan, an Open Minds executive seminar on best practices in strategy, portfolio management, and scenario-based planning. This session will address homelessness in America and how, sorry, that is incorrect. But yes, thank you, and please join us for our December 1st roundtable. Thank you very much, everyone.
Thank you.
Bye-bye.
Thank you.